Picture this. You are 74 years old. You feel fantastic. You are sleeping soundly, your energy is solid, and you are genuinely enjoying your days. Then you go in for a routine annual physical. Nothing special, just a standard checkup. Your doctor flips through your chart and says, "Hey, let's run a few tests just to be safe." 6 weeks later, you are sitting across from a surgeon. Not because something was wrong with you, not because you felt a single symptom, but because those so-called just to be safe tests uncovered something, and that something triggered a chain reaction your body, at 74, simply was not built to withstand. And now, the quiet, comfortable life you were living looks completely different. That story plays out every single day across America. Millions of older adults are walking into medical offices feeling perfectly well and walking out on a path they never chose, all because of routine screening that, according to the evidence, was never recommended for people their age in the first place. The data behind this is staggering, and it is time we had an honest conversation about it. Before we go any further, if you have ever had a routine test lead somewhere unexpected, drop your experience in the comments right now. I want to hear from you, and your story could genuinely help someone else make a better decision at their next appointment. And listen, if you want more straightforward, evidence-based health information like what I am about to share with you, hit that subscribe button right now and tap the bell icon so you never miss a video. This kind of content is exactly why this channel exists. Subscribe, turn on notifications, and let us get into it. Hi, I am Dr. Vanse, and welcome. This channel is dedicated to one purpose: helping adults over 60 understand what the research actually says about their health, in plain, honest language. What I am about to share with you does not come from a single textbook or a pharmaceutical company's talking points. It comes from years of carefully studying the medical literature and paying close attention to what the evidence reveals when the healthcare system runs on autopilot. Today, I am walking you through 5 specific routine medical checkups I would personally reconsider after age 70. What the math actually shows, what can go wrong, and what smarter alternatives exist. Stay with me through all 5, because number 3 genuinely stops people in their tracks the first time they hear it. And number 5 is the one that most people have never even heard discussed until it is far too late. Before we dive into the 5 checkups, I need to give you one framework, because without it, nothing I am about to share will fully land. I call it the longevity lens. When you are 50, screening medicine works beautifully. You catch a problem early, you treat it, and you potentially gain 30 more healthy years. The investment makes complete sense. The math is clean and favorable. But after age 70, 3 critical things shift. First, a significant number of conditions detected through routine screening in older adults will never actually harm you. They grow slowly, they cause 0 symptoms, and statistically, you are likely to outlive them. But once they appear on a medical report, the healthcare system does not have a leave it alone and monitor option. It has a treatment option. Second, your body's capacity to tolerate medical intervention drops considerably with age. A surgery that a 55-year-old bounces back from in 2 weeks can mean months of difficult recovery, serious complications, permanent loss of independence, or worse for a 78-year-old. Third, there is something called the cascade effect. One screening test finds a minor abnormality. That result triggers a follow-up scan. The scan recommends a biopsy. The biopsy leads to a procedure. The procedure causes a complication. And suddenly, a person who walked into a clinic feeling completely healthy is navigating a full-blown medical crisis. All started by a test that was never necessary in the first place. That is the longevity lens. Hold on to it as we work through each checkup. Consider a scenario like this. A woman, 77 years old, a retired librarian with a clean bill of health. She had colonoscopies in her 50s and 60s, both perfectly clear, no polyps, no family history of colon cancer, no symptoms. But her new primary care physician looked at her chart and decided she was due for another one. She had concerns. She did her homework. But she did not want to seem uncooperative, so she went ahead. The bowel prep, the strong laxative solution you have to drink the night before, hit her kidneys hard. By morning, she was confused, dizzy, and unable to stand safely. Her daughter rushed her to the emergency room before she ever made it to the actual procedure. She was severely dehydrated, her electrolytes were dangerously low, and her heart was at risk. She spent 4 days hospitalized, and she never even had the colonoscopy. And the deeper irony? She never needed it. The United States Preventive Services Task Force, the gold standard body that sets evidence-based screening guidelines in this country, officially recommends against routine colonoscopy screening for average-risk adults over the age of 75. The evidence is unambiguous. If you have no symptoms, no family history of colon cancer, and your previous scopes were clean, the risks begin to outweigh the benefits after 75. Those risks are genuinely serious. Bowel perforation, a literal tear in your colon, occurs in roughly 1 out of every 500 colonoscopies. In a younger adult, that is a manageable surgical complication. In a 77-year-old, it can mean emergency surgery, a colostomy bag, extended hospitalization, and a recovery that permanently alters your quality of life. Meanwhile, the colon cancers most likely to be discovered in asymptomatic older adults tend to grow slowly enough that in many cases, they would never cause any harm within a person's remaining lifetime. What to ask your doctor instead? Request a non-invasive stool-based test such as the Cologuard or an annual FIT test. These can identify genuine warning signs without any procedural risk. And if you do have symptoms, blood in your stool, unexplained changes in bowel habits, that changes the equation completely. See your doctor immediately. Let me be precise here, because this topic demands nuance. I am not suggesting you never screen for cancer. Cancer screening has saved millions of lives, and it absolutely can save yours. What I am saying is this. After age 75, aggressive cancer screening in average risk, asymptomatic individuals carries a serious overdiagnosis problem. And overdiagnosis leads directly to overtreatment. What does overdiagnosis mean in plain terms? Imaging technology today is so sensitive it can detect cancers that are, biologically speaking, barely active. Tiny, slow-growing tumors that, left completely alone, would never spread, never cause a single symptom, and never shorten your life. You would die with them, not from them. But the moment a radiologist writes the word malignancy in a report, the clinical machine activates. Biopsies, specialist referrals, treatment decisions, all of it moves forward regardless of whether the cancer actually threatens you. Think about a man like this, 79 years old, sharp and independent, a retired mechanic who was still fishing on weekends. His routine PSA came back slightly elevated. A biopsy confirmed a low-grade, slow-moving prostate cancer. His urologist recommended radiation therapy. He trusted the recommendation and went through treatment. Within a year, he was dealing with chronic fatigue, persistent urinary problems, and a dramatically reduced quality of life. Stories like his are extensively documented in the medical literature. Men who later realized that their cancer was the kind a man his age would almost certainly have lived alongside for years, not died from. Had he understood that earlier, everything might have been different. Studies published in the New England Journal of Medicine found that a substantial proportion of cancers detected through mammography in women over 70 were clinically insignificant, meaning treatment offered no survival benefit, only side effects and complications. What to ask your doctor instead? Have an honest, specific conversation about your personal risk profile. If you have a family history, genetic markers, or active symptoms, screen. If you are average risk with no symptoms, ask your doctor directly. If we find something, what are the realistic treatment options at my age, and what would you actually recommend? That single question often transforms the entire conversation. This one surprises people because it sounds so reasonable. Your doctor says, "You are 72, let us just make sure your heart is doing well." You get on a treadmill or receive a medication that temporarily stresses the heart while monitors track the response. It sounds careful and responsible. Here is the problem. Cardiac stress tests in people without symptoms have false positive rates that can reach 40% or higher in certain populations. That means nearly half the time, the test flags an abnormality when your heart is actually functioning normally. But medicine cannot simply dismiss an abnormal finding. That false alarm launches you into the next phase, a cardiac catheterization. Catheterization means threading a thin tube through your blood vessels, typically through your wrist or groin, directly into the heart. It is a serious invasive procedure. Risks include bleeding, vessel damage, irregular heart rhythm, and in rare cases, it can actually trigger the very heart attack or stroke you were attempting to prevent. And here is where it becomes even more counterintuitive. If the catheterization discovers a partial blockage, which is extremely common in adults over 70, most of whom have no symptoms at all, you may end up with a cardiac stent implanted. Multiple landmark clinical trials, including the widely cited ischemia trial, found that stenting in patients with stable coronary artery disease did not reduce heart attacks or extend life compared to medication and lifestyle management alone. Read that again slowly. The stent offered no benefit over medication, but it carried real procedural risks, and it committed the patient to a lifetime of blood thinners with their own bleeding complications. So the pathway becomes feeling perfectly fine, routine test, false alarm, catheterization, stent, blood thinners, ongoing monitoring, and you are statistically no better off than someone who simply managed the same condition with medication and a daily 30-minute walk. What to ask your doctor instead? If you have no chest pain, no unexplained shortness of breath, no dizziness during physical activity, ask your doctor about optimizing your modifiable risk factors instead. Blood pressure, cholesterol, blood sugar, physical activity, sleep quality. That is where the meaningful gains actually live. This one makes people uncomfortable when I raise it, because osteoporosis is a real condition, and falls in older adults are genuinely devastating. So I want to be careful here. I am not questioning the reality of bone loss with age. I am questioning the automatic pipeline that frequently follows a DEXA scan result in patients over 75. A DEXA scan detects low bone density. The doctor prescribes a bisphosphonate, medications like alendronate or risdronate. You take them for years, assuming you are protected. But here is what routinely goes unmentioned. Long-term bisphosphonate use has been associated with a rare but serious condition called atypical femoral fractures, spontaneous stress fractures in the thigh bone, the very bone you were trying to protect. These fractures can be severe and require major surgery. These medications are also linked to osteonecrosis of the jaw, deterioration of the jawbone that is both painful and extremely difficult to treat. Meanwhile, the single most effective intervention for preventing fractures in older adults, more effective than any medication currently available, is fall prevention. Balance training programs, including Tai Chi specifically, have been shown to reduce fall risk by nearly 50%. Removing tripping hazards from the home, installing grab bars, reviewing medications that cause dizziness, getting vision checked regularly, ensuring adequate protein and vitamin D intake, these interventions reduce fracture risk more meaningfully than any pill, with zero side effects. I am not saying medication for bone health is never appropriate. There are absolutely patients who need it. Those who have already experienced fractures, those with extremely low T-scores, those with specific compounding risk factors. But a routine DEXA leading to automatic long-term medication for an active 74-year-old who has never broken a bone and is otherwise thriving? That is a conversation worth having thoroughly, not a foregone clinical conclusion. What to ask your doctor. Before we discuss any medication, can we go through my actual fall risk factors together? And what is the precise fracture risk reduction this medication offers compared to a structured fall prevention program? This is the one almost nobody is discussing openly, and based on what the research clearly shows, it may be among the most quietly consequential. A carotid artery ultrasound examines the large blood vessels in your neck that carry blood to your brain. The logic sounds straightforward. Find a significant blockage early, surgically clear it, reduce your stroke risk. Clean, simple, preventive. The reality is far more complicated, and for asymptomatic patients, far more dangerous than it appears. Here is the critical fact. The surgical procedure used to address a carotid artery blockage, called a carotid endarterectomy, carries a 2 to 3% risk of causing a stroke during or immediately following the procedure itself. In older adults with additional health conditions, that risk climbs higher. The United States Preventive Services Task Force explicitly recommends against routine carotid artery screening in adults who have no symptoms, no mini-strokes, no sudden vision changes, no neurological symptoms of any kind. Their analysis determined that in asymptomatic people, the risk of surgical harm outweighs any potential benefit from finding and treating an asymptomatic blockage. Here is why. Many adults over 70 have some degree of narrowing in their carotid arteries. That narrowing has often been present for years, stable, silent, causing no problems whatsoever. When you screen for it routinely, you find it, and then a well-meaning surgeon recommends fixing it. But surgery on a blockage that was never causing symptoms can and sometimes does dislodge a small piece of plaque that travels directly to the brain, causing exactly the stroke the whole procedure was meant to prevent. The documented outcomes in the medical literature are significant. People are walking into routine screening appointments and leaving on a completely different trajectory, not because of the blockage that was found, but because of the intervention that followed. What to ask your doctor instead. If you have no symptoms of stroke or transient ischemic attack, no sudden vision changes, no facial drooping, no arm weakness, no sudden severe headache, routine carotid ultrasound is generally not recommended by major medical guidelines. The far better investment is controlling the modifiable factors that actually drive stroke risk. Elevated blood pressure, which is the single greatest stroke driver, blood sugar levels, smoking cessation, atrial fibrillation management, and staying physically active. If you experience any neurological symptoms, even brief ones that resolved on their own, seek evaluation immediately. That changes the clinical picture entirely. I promised you something concrete and actionable, so here it is. Every time your physician recommends a screening test, especially if you are over 70 and feeling well, bring these 5 questions to that appointment. Write them down. Save them in your phone. Use them every single time. Question 1. What is the false positive rate of this test in people my age? This tells you how likely the test is to generate unnecessary follow-up procedures, even when nothing is actually wrong with you. Question 2. If this test finds something, what are the realistic treatment options for someone my age and health status? This focuses the conversation on real-world outcomes rather than just findings on a report. Question 3. What is the procedural risk of any treatment we would likely pursue? This is the question most patients never think to ask, and every procedure carries risk. You have a right to know that risk before you agree to anything. Question 4. What happens if we choose to monitor this rather than treat it immediately? For many conditions identified in older adults, careful, watchful waiting with regular monitoring is not only a legitimate option, it is often the medically superior choice. Question 5. What is the most effective non-invasive intervention available for this condition? Because very often, as with bone health, heart health, and stroke prevention, lifestyle measures and medication management outperform procedural intervention with dramatically less risk and a far better quality of life outcome. Any physician who is genuinely on your side will welcome these questions and respect you for asking them. And if your doctor dismisses these questions or makes you feel like a difficult patient for raising them, that is important information about whether that physician is truly the right fit for you. Let me leave you with this. There is a meaningful difference between medicine that finds things and medicine that helps you live well. After age 70, the purpose of your healthcare should not be to generate findings. It should be to protect and extend your quality of life, your independence, your energy, your ability to do the things that genuinely matter to you. The best physicians I have ever encountered understand that recommending less sometimes requires more wisdom than ordering another test, that choosing watchful waiting over aggressive intervention takes more clinical courage than reaching for the prescription pad or the referral form. You have the right to know what a test is actually looking for. You have the right to know what happens if something is found. You have the right to ask whether a finding would even be treated, and whether that treatment would genuinely improve your life, or simply generate more medical activity. Medicine has given us remarkable tools, but tools are only beneficial when applied in the right context, at the right time, for the right person. You are that person, and you deserve healthcare that is built around your individual goals, your values, and your specific body, not around a standardized checklist designed for someone half your age. If this video gave you a new way of thinking about your health after 70, please subscribe to this channel right now. I put out new videos every week, evidence-based, honest, and practical, specifically designed to help you take genuine control of your health during the years that matter most. And leave a comment below. I want to hear from you. Tell me what you think about this topic, share your own experience with routine testing, and let me know what topic you would like me to cover in the next video. Your suggestions directly shape what gets made on this channel, and I read every single comment personally. For more content like this, subscribe, hit that bell icon, and stay with me. I will see you in the next one. Take good care of yourselves.